We have a very interesting discussion coming up, being moderated by Dr. T.P. Sahoo. And it's a case-based panel discussion, and he's going to discuss about the more controversial sequencing about N1, N2 management. So, of course, Dr. Sahoo doesn't need any introduction for this audience. Over to Dr. Sahoo.
Can I have the panelists, please? No. GTN was good.
Yeah, may I request all the panelists to join over here? Dr.
uncomfortable.
Venkar Krishna, Dr. Dilip, Dr. Vamshi, GVK. Dr. Sushil is not here. Dr. Sridhar, Dr. Sandeep, and Dr. Manjunath.
ठीक है, चलेगा. Not comfortable. It's okay. ठीक है. Sorry. Sushil is not there, na? He's the only one who's not there, na? लेकिन Sushil नहीं है ना खाली.
So 30 minutes.
Yeah, 30 minutes. I will not overtake it. Okay, so we have been given the task of discussing and moderating, discussing a case on N1, N2 non-small cell lung cancers. And we'll be, let's see, the panelists are all there. This is the T staging. I'll just go through, just to remind you, just keep in mind the T4s. And the T3, that is something that we will be discussing when we look into, and especially the surgical versus radiotherapy part of it. That's one point which I wanted to make it clear. And all of us know this, but our focus will be the N1, N2s, and basically the T3, T4s, and the T2Bs. So this is the main focus because we are speaking only of N1, N2. So on this disclaimer, we will be now starting off. So before we go ahead with surgery and chemotherapy versus radiotherapy, if I can ask my surgeon first, Dr. Sridhar, what is your normal way of approaching a PET scan? Is a done thing? I can take for granted that you will always do a PET scan and MR brain?
Yes, sir. If you are planning suspected CA lung, definitely a whole body PET CT and
so if you're looking
MRI
at
brain with contrast. Yes.
Okay, so these two are done, and we'll please keep it with you. So now what beyond? Where do you want to do a invasive procedure like a EBUS or a TB, transbronchial FNA or a mediastinoscopy? Is it valid in today's era? And which subset of patients would you prefer doing that?
So I think any suspected nodal metastasis has to be actually proven in this day and age.
Okay.
We have to go, as we say, from the highest point to the lowest point. That is, you should start from N3 to N2 and N1.
Mm-hmm.
If you have a frank metastatic disease, obviously you need not prove the
That's
extrathoracic metastasis. You don't need to prove the nodal stage.
So this is one point. So you are telling that if on a PET scan you have a node positivity, you'd like to prove it by one of the invasive methods, that definitely. Whether the node is really truly positive or not.
If it is not locally advanced or early and non-metastatic, it has to be proven.
Okay, that's point one. So this is one take home, that if there is something, then there's a chances that you could get a false positive on a PET scan. The specificity is around 80 to 90%. So you still have that 10-20%. So you would like to do a invasive procedure. That's what you are recommending. Now coming down to the second scenario, let's say the PET scan you do is negative, is not picked up anything, but the nodal size is around 1.5 to 2 centimeters. Would you like to still go ahead and do an invasive procedure on that?
So definitely, sir, any node short axis more than about 1 to 1.5 centimeters, you have to prove it before you go ahead with treatment, provided you have the facilities. If you don't have, that's a different thing. You have the facility, you have to prove it.
One should do. So these are two take homes on this, that if there's a PET scan which is showing a positivity, the specificity is around 80 to 90%. Many people have stopped doing it. But if you look at the literature, you should ideally be going ahead in this subset of patients. Point one. Point two, if it is negative, but the short axis is beyond 1 centimeter or more, you can do it. You can upstage it in around 10% of cases. That is what the data is all about. So now let's come down to the panel. So we have, let's say, a case of T3N1, very specific, or a T4N1. Take these two scenarios into account, and or a N2 nodes. So coming to the surgeon first, would you take a T1, T2 multi-station N2 or a single station N2? Does it matter to you? Would you consider it for a surgical approach, or would you give it to your radiation oncologist colleague? The N2s.
The data says if it's N2, as of now you still go for chemoradiation, but I think the next ISCLC staging also has substratified patients into single station and multi-station N2. The main take home is you can offer neoadjuvant treatment of only 3
That
things.
will come into whether you will think of surgery or you'll do the Pacific way is the question.
If it's a single station N2, and if I'm sure I'm going to get an R0 dissection, we'll give some form of neoadjuvant.
So you think that is still operable? And the T4 with let's say the invasion into the great vessels and invasion into the spine is okay. You can still go ahead with it. In the great vessels,
to me, it's operable only if it is a superior sulcus tumors.
Okay. So these are two things which is being very, very put forward. So the radiation colleagues, Dr. Venkat and Dr. Dilip, are you okay with what he told? Would you be able to give that single station N2 to a surgeon colleagues, or would you just want to do the Pacific? Because Pacific did include that subset.
With single station N2, we would still tell them to go with surgery.
Okay.
Because we might prevent not giving radiation for him at all.
Okay. So that looks a good friendship going on, and the N2's single station versus multi-station is now getting more distinct, and people do feel that single station should be more into a multidisciplinary. The surgeons do have a major role to play. That's what is coming out. Okay. So now the medoncs. Now it is, let's say it is a surgical case. All of us know that we are going to go to immune checkpoint, and I think all of us will tell that. So I'll just ask you 2-3 questions. For a N2 or anything that is there for you, which are the patient subset you would not offer, let's say 2B? All the trials have included 2B. Would you go and give these patients the option of neoadjuvant immune checkpoint inhibitors with chemotherapy in this subset of patients? Or would you tell everyone who was in the trial is for me a patient who is a candidate for neoadjuvant immune checkpoint? Anyone? We can start with, let's say, Sandeep, Dr. Sandeep. Yeah, please. Can you speak?
As per the trial, we can give 3 cycles of nivolumab with chemo, and then we can just go for surgery. And then the patient may not require any further IOs.
Agreed.
So for
so we are talking of stage 2.
Yeah.
Okay.
So we can.
So for you, it's immune checkpoint plus chemo as on date for you. Next, please.
I think if it is upfront operable, I'll be considering chemotherapy in the adjuvant part.
Okay.
If my surgeon wants to defer or this.
So here you would leave it to the surgeon to decide.
It's in the MDT. Yeah.
You are not pushing for it in the stage 2B.
Yeah.
That's what you're telling me.
Yes.
Okay, Dr. Manju?
Definitely, if it's N1, we would go ahead and operate the lesion upfront.
Okay, so for you also it is there.
Yeah.
Okay, anyone in the house wants to, Dr. Amol? Stage 2. Would you intend to give a neoadjuvant chemotherapy with immune checkpoint, or would you just want to go ahead and do the surgery first?
No, I would like to give neoadjuvant chemoimmuno.
Okay.
Because some of these patients will end up getting complete PCR.
Okay.
And I will like to give them that benefit. And it has been shown in the trials that the delay in surgery is not much. If the disease is aggressive biology, then it is going to go progress, whether you give neoadjuvant or don't give neoadjuvant. So I will like to give.
In stage 2s also you will give?
Yes.
Okay, I will add on to something and I'll show some data set for that from the so-called landmark trials. Yeah, you want to say?
Yeah, the problem with this approach is you lose about 20-25% of patients who will not come back to surgery ever again. If you, at this stage, if you give chemo, immuno.
The point of patients whom you deem to be surgery fit and are considered operable, if you look at all the trials, there will be 15 to 20% who would not be considered deemed resectable on the table. So you will anyway not get everyone going to get operated. Number 2, if you look at the trials and the data set which is there for all the trials, there is nothing much that takes away from giving neoadjuvant chemoimmunotherapy that goes in favor of surgery for that point which you spoke to.
It is, sir. So this 15-20% number has come from the neoadjuvant trials because they are selecting patients before surgery.
I know.
In an adjuvant trial, the patient is taken after the surgery is done. But if you look at the data of those trials at the screening level, then you will still get 15-20%
And if you
patients who
look
have been not able to do surgery.
How much of the difference is it making whether you give neoadjuvant or adjuvant?
We will come to that question. That question will come to
So
whether
this
we should be
15-20%
considering
missing surgery is same for
neoadjuvant.
both.
We will be considering neoadjuvant immune checkpoint also, something we'll have in a subset analysis. That we'll see. But what point you are making does not hold ground, because if you take the surgical trials, there is a patient's lot of 15-20% depending upon the trials, which have been not operated because they were considered deemed inoperable. So that's fine with that. So that's point number one. So we have Amol on the mics telling us that stage 2, everyone is going to give immune checkpoint, and we will see the data. You always speak of hazards, so there is something which I will always speak. Okay, so point 2 which I want to tell, do you consider PDL1 to be a thing that should be done? And do you think that you should be doing a EGFR ALK also before you consider the patients eligible for any sort of immune checkpoint inhibitors? These are two questions which I told, the PDL1 and the EGFR ALK. So can we start again with Manju, and then we can move here, this side? Yeah, please.
Definitely, we get all the, we get PDL and mutations done.
So you will do PDL.
We
so
do
what
it.
will you do for a PDL more than 50, PDL 20 and PDL 0?
So we consider, first thing is if it's an upfront surgical patient.
No. You are giving immune checkpoint, decided now.
Okay.
Amol told final.
So I refer you to the oncologist for that, medical oncologist for that.
Okay. So please do.
In the neoadjuvant, the PDL1 did not show as a surrogate marker for the response. Like, irrespective, though the high PDL1 has shown a very good response.
So you would still not consider PDL1, you'll do it and keep it for?
Keep it. But
okay. Okay, fine. And for EGFR?
EGFR, better to get it done.
Okay. Can I have, you would be?
Radiation.
Okay, radiation. Okay, please.
Yeah, mainly I think for the
PDL1 is actually, it's
I'll have the medoncs and then I'll have you. Yeah.
So any patient going for neoadjuvant will be having this data mainly for choosing the
Will you
adjuvant.
use it?
Yeah.
Will you consider that while deciding?
If we have someone with the EGFR positive, these are the patients who were excluded from the trial. So probably
No, the 816 excluded them. If you look at the Pembro trial, they did include that. If I'm not wrong, of the AGN also, they did have this patient subset. So only the 816, the Nivo did not include patients with EGFR ALK. The other two did have. So for Durva and the Pembro, if I'm not wrong, they did have this.
AGN I think did not have.
They had. They're unselected. If I'm not wrong, the Pembro surely had. Because there is a subset analysis of the Pembro 871 or 671, which did tell that EGFR ALK did not. So please, you will do that and you will not consider the EGFR ALK. Let's be what you do. And would you take the PDL1 also into consideration?
not for the
No. So we have two things now. Akhil, what do you do in Banaras? Two questions. Do you consider stage 2 to be eligible for, and do you think that the benefit is worthwhile giving the patients? The neoadjuvant immune checkpoint, question number 1, which Amol showed, yes, the panel also supported and half did not. Point is the PDL1 also, because these are two important data sets which we have to look into. Yeah.
So sir, if the patient is stage 2 disease, still the data is robust and we would try to give neoadjuvant neo plus chemo. That is number 1 point. Number 2.
Yeah.
Number 2 is, do you want to look at the PDL1? That is the question, correct,
Yes.
sir?
Would you consider PDL1
To be deciding factor?
Yes.
No.
No.
Not.
Okay. There are two things.
Yes.
Please, the surgeon wants to comment.
yeah, I think the PDL1 is a variable and it is dynamic, sir. That just because your PDL1 45 is not going to be worse than 65 or the way forward.
Yeah, it will change post-treatment or pre. But on that point, when you're considering, you have the biopsy and that is what the PDL1 you will consider. So that's what I meant. Okay, so we have really the house telling what I get is the PDL1 does not matter. EGFR ALK, you will not give. You will not give. While Pembro did show in the data set that it does not matter. In the EGFR ALK, irrespective of, although the numbers are 6 to 8% only, in that subset analysis of 671 keynote, you did find that all the hazards were favoring the immune checkpoint combination. But in the 816, they did not have this subset at all. So this is where it is, but all of us are not comfortable doing it because in the adjuvant data set also we know that the IM power did show that did not matter. But true if some of your colleagues do give it and it's a pembrolizumab, the data set is in their favor. That's what I wanted to just put it forward. And when we look at data set, look across, and you have to see which immune checkpoint you're using. The PDL1 story is very interesting. I'll show you that. Level of evidence could be less than 1, that all of us know. So before I move on to that, type of surgery, a pneumonectomy or lobectomy, or always you will intend to do less than pneumonectomy.
So now we are doing less of pneumonectomies. We are trying to conserve the lung either by doing a sleeve resection or a bronchoplastic lobectomy.
Okay.
Yeah.
So lesser the surgery is better.
If a patient needs pneumonectomy, then we would send it to neoadjuvant.
Okay. Number of cycles are okay, 3 to 4 across the trials. I'm not going to do that. Any data set, any one of you wants to use IO plus IO, non-chemotherapy, or chemo plus IO, anything which you are comfortable with, because there is data set that NeoStar is one of the phase 2 data which was put up last year, that the IO plus chemo had a more pathologic MPR, which was 50 to 55% compared to only IO plus chemo, which was around 30%. Although no phase 3, just to tell you that you have the data set telling you that a major pathological response actually is 40 to 50%, maybe 60% more for IO plus Nivo EP plus chemo, but this is a phase 2. We'll await a larger trial. So just for the completion's sake, I am telling you that. Surgeons, any difficulty in operating post-immune checkpoint?
Yeah, post-immuno, we have had a little bit of experience with surgery. Basically, they have a very thick rind around the pulmonary artery.
Okay.
That's the main problem we are having.
So you do face some
Yes,
issues.
definitely there is a lot of fibrosis. The mediastinal part has a lot of fibrosis.
Okay.
So that's the challenge.
Any other comments on that? No, same?
No, I don't have much experience.
Okay,
post-immuno.
so the trials have shown there's no difference actually. They showed lesser hospitalization, lesser everything towards this part, lesser invasive surgeries, more micro-invasive surgeries. So that's what it was. But all my colleagues which we have spoken to do find more fibrosis. That's what the common comment is coming. This I think we'll skip because all of us know we all want to achieve PathCR. MPR was the previous thing and now PathCR is the major thing. Nadeem, if you look at it, it did show that the PathCR is around 85. It has never been translated in any other trial. All the PathCR, what you see in the major trials around 30-35%. That's what you see in the combination. And the immunotherapy, single agent chemo, it's around 8-10% or 11%. That's what you see. So basically the delta is around 20%. That's what I keep remembering. Nadeem is outlier. The 71% will never happen, I think so. And that was something you'll never see. Okay. This is well told that if you achieve a PathCR, irrespective of what agent you use, you're going to do well. I'll skip this part just to come to the point which I wanted to make. Pacific. I'll come to the PDL1 because my slides are later on. The PDL1 is stage 2. I'll come to this one and then I'll combine both the data sets. So now, which are the patients? My radiation colleagues, I think I can come down to someone who has not spoken yet. Sorry. Which are your patients whom you would not fit okay to refer it to your surgical colleagues, or you find the patient is best suited for a chemoradiotherapy?
I think with the multiple station N2 nodes is one which is suitable for radiation. Someone with a T4 and an N1 is also with infiltration into the chest wall.
Chest wall is T3. And chest wall is actually, most of surgeons feel they're okay operating. I don't feel they will ever give it back. Is T4 is something I'm looking at is the major vessels. If there is a massive invasion into that, if there is something that is going into trachea, major thing, those are things I think the surgeons are now not comfortable and they feel that we can go ahead. Any thoughts?
One more is a node which has got external extension radiologically, which might be not resectable.
Okay.
That we can take it up.
So let's come to Pacific. We all agree? Yeah, please, you want to say.
Point. If it's a, when you're talking about nodes, we also have to see how bulky they are and whether they are multi-station, multi-zone or single zone multi-station. So I think that is.
So multi-station is one which we are okay with giving it to
giving radiotherapy.
And T4, half of the T4 surgeons would not be okay operating.
Agreed.
T4 N2s are the group which you are really looking at to give it to the Pacific.
That I think directly.
But to be fair, the Pacific had 3As, and for 50% of the Pacific were 3A, although the criteria that was used, the patient who were deemed to be not operable in the tumor board were taken up for Pacific, but we can debate upon that, but Pacific did have the 3As. Okay, so let's see my dongs again. We have taken the patient, they have given chemoradiotherapy. So who are the patients whom you feel would you not consider for durvalumab? What has been your experience? How fast can you initiate durvalumab is the second question which I'll ask. And do you consider the EGFR ALK and the PDL1 to be significant here? 3 points.
We normally have given durvalumab in the real world practice around 3 to 4 weeks post.
So you are able to achieve that 6 weeks time period?
Yeah.
And most of your patients?
Most of the patients.
Okay. How many of your patients who you take up for chemoradiotherapy ultimately do not receive durvalumab apart from financial reasons?
I think majority because of the financial reasons.
No, apart from that.
We have not, very few, we have, most of the patients, because of the financial reasons.
That's what, leave that.
So the denominator is very less to say, very honestly.
So PDL1?
PDL1 did not make any difference, but the EGFR ALK made a difference.
So PDL1, you're okay doing it for any PDL1?
Yes,
okay.
But EGFR ALK, we had a difference because we had a phase 4 Durva trial where any EGFR ALK...
So for you, EGFR ALK, no. For PDL1, any, you will give it?
Yes.
Okay, we can move on.
Yeah, I think mainly for the lung volume which is radiated actually, if the few patients who might have received a larger volume to the lung, we will be a bit skeptical in considering.
So what percentage ultimately you find them not fit enough to go for Durva?
Probably around 10-20%.
20%, fair, there's the data. And for the PDL1 and EGFR?
EGFR, yes, probably I'll be considering adjuvant TK, but for the PDL1, no.
No, you will still all comers for them. Okay, yeah, please. Yeah, 2.
I have an instance where I gave IO plus chemo. Patient didn't agreed for surgery. It was his personal decision. Then we gave definitive CTRT. Does this patient warrants adjuvant durvalumab?
So patient,
we had a good response on PET scan.
I understand. So how I will take it is, I will extend the benefits of Pacific to this patient. If I have to, but Pacific did exclude patients who had received prior immune checkpoint. So that is the reason I will probably deny. If the patient had received only chemo, I would have given the Pacific to him. If the patient has received immune checkpoint before, a different immune checkpoint, I'll be skeptical. That's my take.
Does Pacific stops your second line protocols?
Pacific, how they defined is, if someone who has had a relapse post 1 year could be re-challenged even with durvalumab. So they're very clear about it. And I think we have to follow that. If someone has received a chemo, give the Pacific to him. If someone received an immune checkpoint, let be the adjuvant decide. I'll stop there probably. Please.
Rapid comments. Number 1, completion rates of adjuvant durvalumab is 40 to 50%, not more than that. Second point, there is a RICAL trial from Italy where the PDL1 negative patients at the baseline before CTRT became PDL positive, 50% patient became PDL positive. Third point, the new trial Pacific 8, which is randomizing in India, it is only for PDL1 positive. So even the company which is sponsoring the trial knows that it is mainly beneficial for PDL1 positive.
It is in public domain. Yes. I have to see the data. The data is there. We have to just accept it. It has been published. Let's see what the data is. And I agree to most of you points. If you look at, there is a Pacific R, which has been put forward. There's a real data for Pacific, which was published 1.5 years back. This is some data set which you should always look at Pacific trial itself. Combine both the things, you will see a lot of things really coming out. The Pacific R is a beautiful data set for real life patients who have received the Durva on a compassionate basis. That was published. So they feel that 30% cannot receive the consolidation durvalumab. They cannot start because of progression of disease, which is around 8 to 10%. The PS deteriorates to a condition of that they cannot receive, and 8% somehow have interstitial lung disease because of the volume which is irradiated, which was spoken to by one of the panel. So 1/3 will not. 33% are PDL1 negative in the Pacific. Across all lung cancer, you'll see that 35%. And the data set is very, very clear that they do not benefit. Even the Pacific OS updated analysis, the subgroups tells you that the PDL1 negative do not benefit. That is why this trial has come in with that they have excluded this patient. They know the EGFR is 8%. And there is also one more data set that if you do not, the earlier you start better, 14 days was the initial part, they extended it to 6 weeks. People have also started up to 3 months. But the later you start, the lesser the benefit is, something all of us to remember. So to this is the subset analysis. And if you look at it, look at the last one, less than 1 and more than 1, you will find the difference stark there. And the numbers are not less, the lesser, the last point. And the EGFR ALK is also there for you to see. So this is the updated OS subgroup analysis from the Pacific. So for me, for PDL1 negative, I will not give. I'm very sure that is not benefiting. For EGFR ALK, I will not give. That is my take. As per the approval, yes, you may. No one is going to hold you for that. But I think we have to be, these are costly drugs. We have to start choosing our patients well. That is my take on it. Coming to what I spoke of, the 816, this is the PDL1 negative data set. And look at the PDL1 negative data set that's on the left side. And when the 816, if you divide it across in the main publication, if you see the PDL1 negative, see the curves, and if you look at the curves of the event-free survival itself, it is just overlapping. Amol has to see that. So these curves are very, very important for us to see. For a costly drug, would you like to give it? And this has been shown for every of the trial which has been published in the neoadjuvant data set. And now I want to show you as per stage. This is stage 2. The other one is stage 3. And yeah. So basically, if you look, yeah. So 1B, 1 minute. For the stage 2, look at the Nivo data also. And so look at the Pembro data also. It's looking similar. So my point is, you are okay with giving it. But when I start choosing who will benefit the most, I feel that this graph should be there in your mind, that do not push that much for a stage 2. For a stage 3, push. You are going to get it, but I agree. The person who is going to get a PATH CR, they are going to do extremely well. There's nothing wrong. I'm just putting a data set for yourself to take into care.
So again, same point, sir. So if we go back into all the data of perioperative, we see that patients with stage 2 derive the maximum PATH CRs. The benefit that we see in stage 2 compared to stage 3 is predominantly because of the control arms. The control arm in stage 2 does not do as bad as the control arms in stage 3.
Exactly. So why to add?
So again, that's the point, sir. The PATH CRs are higher in stage 2s than the stage 3s with the addition of immunotherapy. I think the trials are all on 3 years old. 2020 is where most of these trials have started. Probably 2025,
the
2026.
event-free survivals are matured. We are just going to get comments on the OS data.
No, I think
that is something we have to remember.
Stage 2, we can see a lot of censoring happening, sir. I think, again.
I take Amol's point. This is the combined thing. But what I want to say you is, most of them were stage 2 in the 1B2. So it is up to you. The point which I want to make is, the graphs do tell a story. It is up to you to take it or not to take it. In contrast, look at the Pacific. It's a very beautiful graph. But you have to exclude those patients which we have spoke. I'll just skip grounds. I'll not touch this, just to reason we have spoken this apart. I will just go to AG, and also I'm going to skip this. This is all spoken about. I will come to one set of the things which was there for adjuvant. I'll take home for the neoadjuvant for what I felt. For 3A, evaluate for surgery, NSCT with immune checkpoint followed by surgery is the standard of care as of now for someone who can afford. For the rest, concurrent chemoradiotherapy. For stage 2B, some probably can be operated in some select centers. It is not a standard practice, but majority will be eligible for Pacific. Would someone offer neoadjuvant with immune checkpoint to stage 2B? Yes, some will, some might not. PDL1 negative, the data is there for us to look into. And this data set tells you a story. The graphs do tell a story. It's up to you again. EGFR ALK, if you have to use it, you're so much bought into this protocol thing, then do Pembro, don't do Nivo. That's my take on that. 3C, unlikely to be offered surgery. Pacific is the way ahead. But I think there are case reports which you will find in 3C also. Give immune checkpoints and chemo, they cytoreduce and then you operate. But that should not be the thing. My point is, neoadjuvant immune checkpoint is a watershed moment in operable locally advanced NSCLC. That's here to stay. The second point is, quickly, 3 minutes, adjuvant therapy N1, N2. I'll come to my radiation colleagues first. Would you give adjuvant therapy for an optimally operated stage, let's say N1 first and N2, quickly?
For all the meta-analysis in the phase 3, they did not show any benefit.
So you will not give. Perfect. My thing is done.
N1, no. N2, I would think of.
You will select patients.
I'll select patients in
Which
N2.
patients?
So N2, if they got multi-station involvements or multiple nodes, if I say the lymph node positive ratios with post-operative nodes are more than 50%, they might still have a higher recurrence rates. So those selected patients I'll take, and even R1 positive patients.
Okay, that's
or
done.
patients having external.
So actually, that's somewhere in between. N1, no, that's what it is. N2, people start selecting high risk and not the so high risk. The high risk they have considered if more than 4 nodes are still positive post surgery. If they feel that post NSCT of immune checkpoint there is still a residual disease of nodes left behind. If these are the 2 patients they feel, or the multinodals, they feel that probably port can help. But again, the level 1 evidence is lacking. That has to be told very, very clearly. But you can still select this patient.
But someone who is going neoadjuvant chemo, I think the post-op trials included the patient has to be proven that mediastinal nodes are positive by
Anyway,
EPS.
they're operated, so you will have those things positive. So quickly, immune checkpoint inhibitors and adjuvant, last minute. Would you give? If yes, what?
Yes.
Which protocol? Atezo or Pembro?
Atezo with mainly for those with PDL1 at least of 1% or more.
So more than 1% you will give Atezo?
2 and 3, yeah.
Or more than 50%?
Definitely for anyone who is more than 1% will consider, but it is more benefit for those who have 50%.
EGFR ALK, no.
No.
Please, next comment.
Atezo, the controversy is there. More than 50 selected, very few, but not as overall.
So you will give Pembro?
Pembro, the benefit is much more clear.
No, actually it's other way around.
No.
The Pembro, they lost the benefit, actually more than 50%. That is the irony of the Pearl trial.
Pembro was irrespective of the PDL1.
But if you look at the analysis, this also was a positive trial. Both are positive. I'll tell you quickly, last 10 seconds. If you look at the IM power, if you look at it, EGFR ALK, we won't give it, it's all done. And look at the PDL1, more than 1% and more than 50%, all this have seen it. Basically the 1% is driven by more than 50%. So with more than 50%, you're more convinced of the benefit. This is the data set of Pearl, the Keynote 091 and the IM power. The only thing was both were positive, but if you look at the more than 50%, which was a planned analysis for the Pearl trial, it was somehow negative. No one knows why. Could it be because of less number of smokers that was there? No one knows. But the take home is, if a more than 50% Atezo looks more robust for you, for all comers, as the stage tells you, you can give it. An adjuvant immune checkpoint should be given for a patient whom you feel more than 50% or otherwise more than 1%, and has to be EGFR ALK negative. That is where I stop. If there are anything more, sir can have the last word.
So very well done panel, very learned panel, thanks. When we started oncology, several of my age people are here in the hall. We had only 5% operable lung cancers, gone up to 20-30% now. Stage 1, again, management is primarily surgery. Stage 2, 3, we have options now. So it is no longer the situation who the patient goes to, that treatment the patient is given. Every patient of early stage lung cancer, potentially curable lung cancer with local treatment must be discussed in a multidisciplinary tumor board. I think that very clear-cut message has to go. If you have a patient of stage 2, stage 3, starting straight away with radiation or doing the surgery straight away is not the standard of care today. Patient has to be discussed, or multimodality treatment has to be planned.
Thank you, and Nikhil, I'll stop here and give you 1 minute late. Thank you. Thank you, panel.
Yeah, thank you, Dr. Sahoo. Thank you, all the panelists, for the wonderful discussion. And we have next